So as we know, the anti-PD-L1 monotherapy results in a response in a minority of cancer patients, and likewise when you combine it with CTLA-4 targeted therapies in lung cancer. So the question is, which patients, who are the patients that respond to therapy? And fortunately, the Grim Reaper I showed earlier is now in big retreat because we're moving forward fantastically well with immune therapies and also with targeted therapies, particularly Ben here with the work he's been doing. So this is looking at the three main classes of biomarkers. This is a slide from Solange Peters, which shows that we have three big areas of interest. The first is PD-L1 immunohistochemistry. The second are surrogates of immune response. This has been a bit disappointing actually in terms of clinical trials and coming out as a good marker. And the third has been the mutational burden, and indeed increasingly now the assessment of neoantigens within the tumour. I showed the slide earlier showing that with PD-L1, the higher the expression level of PD-L1 on the tumour, the more likely you are to have a response to therapy. And I suppose with Pru, it would have one slight difference in that we actually use 50% of cells as a cut-off potentially for single-agent pembrolizumab. So we do depend on you, Pru, to tell us there's more than 50% of cells there. Or is she here? Okay. So that's really important. The first study that came out in lung cancer was the Checkmate 057, looking at overall survival in adenocarcinoma. And this study, when it was reanalyzed, looking at PD-L1 expression, showed that tumours with a PD-L1 expression, it's really this that matters, over 10% were likely to have a survival benefit, whereas those below that level were unlikely to have a survival benefit. They were equivalent to chemotherapy. So this trial comparing nivolumab versus chemotherapy, positive trial, very important, established our practice, but it's really the high levels of PD-L1 expression that seem to matter in non-squamous, non-small cell lung cancer. And this was then applied to the Keynote 024 study, looking at patients with metastatic non-small cell lung cancer. Would high levels of PD-L1 expression over 50% of cells matter? Could you select a population that would do very well? And this trial compared Keytruda versus chemotherapy, and you could cross over. It was a positive trial. The patients who got Keytruda versus chemotherapy had a very significant progression-free survival with high levels of PD-L1 expression in the tumour. And when you look at progression-free survival initially and then a crossover, when you look at the second progression-free survival, this allows us to assess the impact of crossover, and the curves continue to separate. And the reason why that's important is because with EGFR targeting kinase inhibitors, when you do that, the curves come back together again. But with immune therapy, they continue to separate. So it tells you that giving your immune therapy up front, if you're going to be sensitive to immune therapy, really matters. And this was the first study to show this. So that's a really important endpoint. So it's an important marker in that for picking out that group of patients with a high chance of responding to therapy. But it has to be emphasized that it's an enrichment factor. It doesn't tell you who you shouldn't treat. It says you can treat these people, but it doesn't tell you who you shouldn't treat, because if you've got no expression, there's still about 8% of patients respond extremely well, and the response lasts just as long. So it's an imperfect marker, it's an enrichment marker, but useful in this particular situation. Response rate is higher than chemotherapy. What about squamous cell? So squamous cell is slightly different, because with squamous cell, we had the checkpoint 017, the first study to come out. I said the 057 was the first, it was actually the second one. This, I think, it was the first one. You can correct me if I'm wrong, Ben. And this showed a survival advantage for patients with squamous cell lung cancer who got nivolumab versus chemotherapy in the second line setting. Okay, single agent. But in this situation, the PD-L1 expression didn't matter. So irrespective of your PD-L1 expression, in squamous cell, you seem to get a benefit from therapy. Okay, when we look at a combination study, this is Keynote 407, looking at chemotherapy plus pembrolizumab versus a placebo plus chemotherapy. You can see here the overall survival is positive, but when you look at the different subsets in terms of survival, there isn't much difference in terms of magnitude of benefit. Now, maybe that the high levels do better, slightly better, but overall the magnitude of benefit seems the same across, in terms of survival, across all the groups. It's kind of interesting. So maybe it matters less in squamous. This is not the absolute story. There is variation in the studies, but this seems to be more important in adenocarcinoma for enrichment than it may be in squamous cell. And then what about small cell lung cancer? We often forget about small cell, but this is a nice study looking at PD-L1 expression in small cell lung cancer. About half the patients had some expression. It doesn't tend to be as high as in lung. And what we see from this slide, and this is important, is this particular one here, that if you're PD-L1 positive, you do better than negative, and your response rate is also significantly higher if you're PD-L1 positive than if you're negative. Now, we need more studies in this because it's phase 2 data. It's early data, but it certainly seems to be, if you've got an immune marker that predicts benefit, perhaps it is important in those subset of patients. So we need better markers to pick out the best patients, okay? And we've talked earlier about the clinical kind of markers we have, which is LDH and neutrophil lymphocyte ratio, perhaps radiomics. But here we're going to talk a bit about the tumour mutation burden. And so we know that lung cancer tends to have a high level of mutations. And if you've got non-synonymous mutations, you tend to do better than if you don't have non-synonymous mutations. So the first study, which was a big study, was looking at the Checkmate 026 study, because this trial essentially was comparing chemotherapy to nivolumab first line with a PD-L1 score of greater than 5% of cells, tumour cells positive, and it was a negative study. In fact, actually, in terms of progression-free survival, the curve was against immune therapy at the beginning. Okay, so could there be some group in there that was benefiting? So they luckily had collected sufficient samples in over 500 patients in this study to look at the tumour mutation burden using whole exome sequencing. Okay, and they had the germline available. And what they found was that squamous cell tumours tend to have, in general, a slightly higher level or are more likely to have tumour mutations than non-squamous, which is in keeping with the fact these are often smokers. And what was found is that in the nivolumab arm, that if you had a high tumour mutation burden versus a lower medium score, and these are arbitrary scores, but we're learning about, at this stage, people were learning about this, that the high group did well, and the opposite was the case for chemotherapy. And then if you compared high tumour mutation burden for nivolumab versus chemo, nivolumab did better, and the opposite was the case if you had low tumour mutation burden in this particular study. But there was no correlation between PD-L1 and tumour mutation burden. No correlation. Okay, and when you combine tumour mutation burden with PD-L1 high, you seem to get an extra little lift in terms of outcome. So this was obviously retrospective, so as such needs a bit more work. But this is the 568 study. This was designed to look at PD-L1 expression and response in a phase 2 study, and then tumour mutation burden was added in subsequently. But some really nice data came out of this, in that if you had PD-L1 expression greater than 1%, and you had a high tumour mutation burden, that was your response rate. If you had PD-L1 high with a low tumour mutation burden, and it is a slightly arbitrary cutoff, okay, then you still got a reasonably high response rate. Whereas when you flick over to tumour mutation burden in PD-L1 negative cases, you're now getting down to much smaller numbers benefiting if you've got a low tumour mutation burden. Whereas if you've got a high tumour mutation burden, the response rate's identical. So tumour mutation burden looks like it's important. Okay, in terms of response. This was the nature of the cutoff, where using a foundation medicine panel, 9 to 10 mutations per megabase was shown to be a reasonable cutoff, but it is arbitrary. You can see it is selected based on a curve, ROC curve. What about nivolumab plus ipilimumab versus chemotherapy? So this was the Checkmate 227 study. It's a sort of an octopus type trial design. 1,800 patients have been recruited to the study, and sufficient tissue is available for over 1,000 of these patients to get tumour mutation burden. And this looked at patients with a high tumour mutation burden, comparing nivolumab and ipilimumab versus chemotherapy. This is the first arm to be reported. You can see nearly half the patients have a high tumour mutation burden by this assay. And the key here is that the combination in terms of progression-free survival is better than chemo. So high tumour mutation burden seems to correlate with some benefit compared to chemotherapy, and a really nice duration of response as well. Okay. When we look at patients based on PD-L1 expression, whether it's low or high, exactly the same as the 568 study, tumour mutation burden identifies patients who are benefiting. Okay. So whether it's a low PD-L1 expression or high, you're seeing this benefit. And in squamous or non-squamous, the same thing. And there's a trend towards an improved overall survival with a hazard ratio of 0.79. So that is immature data. It needs to mature now over time. What about the second part of this 227 trial to be reported? This was in patients with a low PD-L1 expression, comparing chemotherapy based on histology with nivolumab plus chemotherapy, and also bringing in the nivo-ipi arm. And you can see that nivolumab plus chemo was better than chemotherapy. It achieved its primary endpoint, not startling. The duration of response was better, but the curves come together over time. Higher response rate. And this is nivo chemo versus based on tumor mutation burden. All the benefit seems to be in those patients who have a high tumor mutation burden for nivolumab added to chemo compared to no addition in the nivolumab chemotherapy arm if you have a low tumor mutation burden. And when you look at the ipi-nivo data in this group of patients, again, less than 1% PD-L1 expression, you can see it's superior, the combination of the immune therapy versus nivo chemo versus chemo. Now, it has to be emphasized, and really with very little benefit in PFS over here. But it has to be emphasized that this is progression-free survival. You know, we need overall survival because the curves may separate out with time for overall survival. But this is remarkable. Again, the duration of response, if we responded to nivo and ipi, is really good, just like we showed in the first study. And this is small cell, and you can see here, if you've got a high tumor mutation burden with this combination, again, it seems to identify a group of patients that are doing well. So tumor mutation burden might really matter, okay? But what about heterogeneity in tumours? This is work done by Charlie Swanton. This is just, the next slide is not a bit fuzzy, but it shows the idea of a private, a shared, or an homogeneous expression of clonal neoantigens, okay? And it shows that if you have a homogeneous expression in all your different biopsies, those patients do really well. If it's shared, so that a few of the biopsies are positive and some are negative for your neoantigens, they do a bit better. And if you have only a private one, so there's basically one of your biopsies is positive, they don't do so good, don't do so well. And that's kind of nice. That fits in with what you would expect from the biology of the disease. And that's been brought out in a number of studies since then. So we've got PD-L1. Okay, it's like a continuum. The higher your levels of PD-L1, the more likely you are to do well, particularly in the first line setting if you're using single agent. You need a high expression really to get a benefit at the moment, based on the data we have. We've got tumor mutation burden looks pretty promising, but there's loads of assays. We don't know what the ideal cutoff point is. We haven't selected it yet. And it may be like PD-L1, it may be a continuum. And we maybe have to arbitrarily say, this is the point we're going to use. Okay? Then we've got pre-existing immunity. And this looked interesting. The TEF score looked interesting. This was in the Roche study early on, popular study, where it looked like, based on your baseline immune profile, you could actually predict who's going to benefit. Unfortunately, when the main study was done in the OAK study, this benefit was really marginal. It didn't really pick out the group that was doing well any better than the PD-L1 score. So I think this was a bit disappointing, but that's the way it goes. You know, we test markers, and they get buried if they're not good enough. What about radiogenomics? I just want to just mention this. Or radiomics, it's non-invasive. It looks at the whole tumour. It looks at multiple disease sites, multiple time points, and it's dirt cheap, okay, as a baseline study. Everybody gets a baseline CT scan, okay? And so you go, this is the current model, CT, biopsy, mutation detection. Radiomics is CT scan, radiomics, and then mutation probability. And it's a bit like the idea of looking at Monet's water lilies. This is actual garden. This will be the texture analysis, okay? So our data shows, based on different things you measure within the tumour, I'm not an expert in this area, but I'm just going to show what came out in our study. You have a thing called skewness in entropy, and skewness and standard deviation in your assessment of the different pixels that you analyse. And you can see here, with our study, we were able to pick out really all the patients. This is only 39 patients, okay, in total. We were able to pick out those patients that appear to benefit from nivolumab second-line therapy. So maybe by developing this further, we'll have a radiological test at baseline that will tell us who's going to benefit. How are we doing for time? So, and this is a patient combining radiomics and immunotherapy. We did an in-house analysis. The patient had a high tumor mutation burden, it was KRAS mutant, and the CT detection analysis indicated that the patient was likely to respond to therapy. So maybe combining things will give us an idea. In this patient now, she had a sarcomatoid lung cancer, KRAS positive, had an excellent response to therapy. She's 3 years out now and remains in remission. She also, by the way, has had pneumonitis, low grade, didn't need treatment, and she's had arthritis. So she's getting toxicities, all of which tend towards benefit. And then it's also possible using PET imaging, dual-time PET imaging. Tumour cells take up FDG and hold it, whereas inflammatory cells take up FDG and then excrete it, they push it out of the cell again. So if you do 2-time PET imaging and you get a reduction in your PET signal, it shows that you've probably got an inflamed tumour. It's kind of interesting. So this is something that we're exploring at the moment in our group. So the conclusions are that PD-L1 expression absolutely enriches for response and survival, but it doesn't exclude patients. It doesn't tell us who's not going to benefit. That's the problem. The tumour mutation burden is a novel biomarker. It needs a bit of work, but it looks very, very promising. The pre-existing tumour immune profiles remain to be proven. We don't really have a strong signal just yet, and maybe we can discuss that further. But what we do know is that things that suggest that you've got an immune suppressive environment, like performance status, tumour mutation, neutrophil lymphocyte ratio, LDH, that they may be important and clinically telling us who's likely to benefit. And radiomics, I think, could be something for the future. Because having a baseline CT scan and getting a readout straight away on the likelihood of benefiting from therapy will be really, really helpful in the clinic. Thank you very much.